everybody. First of all, it's a great pleasure to have Professor Grossman for this interview for our EYRC training program. Professor Grossman is well known to all of us. He's a professor of Neuroendocrinology, did most of his career at St. Bartholomew's Hospital and Barth at the London School of Medicine, also in the University and the Hospitals of Oxford, and is now a consultant neuroendocrinologist in the Royal Free Hospital, where he mostly treats the patients with the neuroendocrine tumors. His interests are mainly about endocrine tumors, mainly pituitary, adrenal, and neuroendocrine tumors. So, your topic today was about ectopic Cushing syndrome. What are the main diagnostic and therapeutical challenges in this entity?
Well, thanks very much, Pedro. I agree. It's a difficult area and it remains challenging. I think one of the major problems is that while the diagnosis of severe Cushing's does not really make a problem, if it's ACTH-independent, we're usually straightforward, heading for the adrenal. But once you know it's ACTH-dependent, it can be quite difficult to know whether we're talking about Cushing disease, pituitary-dependent Cushing syndrome, or an ectopic source, because classically the ectopic source was large, metabolically highly active, and it was usually quite obvious. But increasingly we see patients overlapping in their age group, overlapping in clinical features, when it's really quite difficult to be sure whether you're dealing with Cushing disease on the pituitary or whether the tumours elsewhere. Now, particularly very small, particularly bronchial carcinoids, can have all the features of a corticotrophic tumour. It's almost as though you've got a little ACTH secreting tumour, which is not in the pituitary, but it's somewhere else, in the thorax, in the neck, in the pancreas. And as it can have many dynamic features, biochemical features of a corticotrophic tumour, and it can be very small, then being sure of the diagnosis can be really quite difficult. And you obviously have to be sure because the treatment for Cushing disease and ectopic source is completely different.
The second question is now related with this problem that we are now facing about the CRH shortage. As you know, pharmaceuticals stop producing. We don't know how long this will be, maybe if they will ever restore the production. So how impactful this situation do you think it is for the medical practice in endocrinology, and how best to overcome this issue?
I think it has become a really quite difficult issue. At first we thought it was catastrophic, and people like myself who work with CRH all our professional lives have suddenly found ourselves without what should be a major investigatory tool. But like all of these things, given a bit of time and a bit of thought, I think we're making very good progress in seeing life after CRH. We know that desmopressin is cheap, and secondly, in many aspects, in many respects, it can be used as a replacement for CRH. Now, some people like to use both CRH and desmopressin. Well, that's unfortunate, we can't do that. But I think being very careful and looking at the advantages and possible disadvantages of desmopressin, I think we can use that in place of CRH in many situations. And it's not the be-all and end-all, and I think we can move forward. But I would also like to emphasize that for many years, because of the cost of CRH, doing bilateral petrosal sinus sampling, many centres have been using desmopressin anyway, and meta-analyses of the data suggest that actually for BIPSS, desmopressin is pretty well as good as CRH. So there are slight disadvantages, might be slightly less good, but overall I think we're going to learn to cope to do without CRH, sad as it may be. And if it comes back at some point in the future, great, and if it doesn't, we'll modify our protocols accordingly. So it's not the end of the world.
So this next part of the interview is more career-related advice and tips for us. So I would like to start by asking you what are your advice on how to combine the best clinical and research activities and how to become a world leader academic endocrinologist?
I think that's a very valid point, that it is difficult, I have to accept at the beginning, to be a very active clinician and to be a translational researcher at least. I'm not talking so much about basic research. But I think translational researchers, people who bring their scientific knowledge and understanding of what's changing in biological science to the clinical situation, I think these people are really very important and have to be valued. And secondly, I think we can do it the other way around, that the clinician takes to the scientist what are the vital questions that need to be answered. So I think first of all, one doesn't have to be one or the other. A good situation is to work out a balance between the two that you're happy with, 20% one or 80% the other, either way. It is difficult to get that started, to get the right position that will offer you that opportunity. And it may take lots of false starts in different places before you actually find that balance. But what I would say in general is, first of all, the thing that cuts through everything is enthusiasm. If you really are interested and if you've got a problem you're concerned about or you want to solve, you can cut through a lot of the inhibitions or parts of the pathway that are trying to block your progress. Secondly, I would look around and find a unit, a group, a person whom you personally would respect, want to work with, and that you would enjoy working with. But that's really important, to come into the lab in the morning or the clinic and like your colleagues, probably an undervalued part of our work. And look around and change your job if necessary, and keep looking, go to meetings, meet up with people, network, until you find this person I think has really got the right ideas. I'd like to work with them, develop my career in this area, show my enthusiasm, and then things will eventually fall into place. It does require perseverance, it does require enthusiasm, but for me personally, the balance between acute clinical medicine, endocrinology, and the translational work or doing research, I think has been absolutely stunning, and has made my my professional life really well worthwhile. And of course, you then need to balance that with your home life and your personal life, which you mustn't neglect, which is an important part of what we all do. But to triangulate and bring all three together, it may sound like perfection, but with the right will, I think most people, if they really want it, will do it.
Okay, thank you for the thoughtful insights. It's really helpful for us. I think now another important struggle of young early career scientists and endocrinologists is to publish in high impact factors. And you are now the endocrine, the editor-in-chief of Endocrine Review. So could you give us some advices to publish in high impact factors?
That's an interesting area. First of all, I think what I've seen in younger research is an overemphasis on impact factor, and they will spend hours going through a journal which has got a 0.1 of a more of an impact factor than another one. Fundamentally, if you're doing good work that's relevant and that's going to make a difference, in a sense it doesn't matter where you publish it. As long as it's on PubMed and as long as you can present it, as long as people are aware of what you're doing, then the journal is much less critical. Of course, it always looks good in applying for grants and going to meetings to show your paper in the best possible light, in the best possible journal. But I just don't think one should overemphasize the nature of the journal. I think you need to do really good work. You need to make it complete. You need to be able to tell a story. You should not salami slice your work where you just put up bits of data here or there. And something which, there was a Nobel laureate who I met a long time ago, Pedro, and he said, which I've always thought about, you'll only get big answers if you ask big questions. So don't trundle around just doing work because someone said it was going to be useful for your career and it's not interesting, it doesn't raise your enthusiasm. Yeah, if you ask a big question, 90% of the time you'll get the wrong answer, it won't work out, your theory will be wrong, your speculation inadequate. But you've got to have something you really want to know the answer to. Now, I'm not saying you say, how do I cure cancer? But I do think that to keep you going, working late in the lab, getting up in the morning, having ideas in the bath, you've got to have the enthusiasm to ask a good question. Now, to be able to do that to begin is difficult, and therefore, again, you need to look around to a department, a unit, a hospital, a university, where they are interested in what you're interested in, and where you feel you could fit in and start asking your own questions in due course. Now, the other thing is, and in basic sciences people disagree with me, I think writing reviews in the first instance is very helpful. In some really big major science departments, they ban their postdocs who are doing any sort of writing reviews. It takes their mind off it, and it deflects them from what they should be doing in the lab. But I think as translational clinicians, it's very useful because it allows you to focus your thoughts, to pull a lot of data together, to think what the real problems are. And if you only, when you write the review, you suddenly realize where the gaps are, where there's disagreements, where there's, frankly, if you read things very carefully, where people are plain wrong. And that allows you to develop a really critical faculty. Very often, very senior members of departments are asked to write reviews for major journals like Nature reviews. They're not going to come to you, because they don't know you. But if you're around and you're enthusiastic and the person you're working with appreciates what you're doing, then it's the first step on the ladder to put that together, get your name in lights, people to become aware that you are the person who does X, Y, or Z. And in the same light, fairly early in your career, and I was told this, and I'd made that mistake, I was just being Mr. Every endocrinologist. I was doing thyroids and pituitaries and adrenals and you name it. I thought, well, that's fun, I'll have a go at that. But fairly soon you need to be known as Mr. Pituitary or Miss Adrenal. You know, you need to start honing in, find the real problem, and be known that you're the go-to person for that particular type of problem, type of disease, looking at the new work in that area. And once you find it and you're enthusiastic about it and you can see a way forward, then, you know, the world's your oyster.
So, Professor Grossman, thanks very much for your insights. They were super helpful and very helpful, hopefully, for all of you and all of us young researchers and clinicians. And thanks again for your time, and enjoy beautiful Algarve, and see you next time.
Well, it's been lovely being here as ever in Portugal, and if I can help people enjoy their careers as much as I've enjoyed mine, then maybe we have been beneficial. Thank you.
Thank you.